So just to kind of put everything in perspective, the first lecture focused a little bit more on the prevalence of disease, this new wave epidemic, the fact that it's something that we definitely need to be monitoring and attentive to. The lectures at lunch are going to focus on your team-based approach to how to deal with this, practically speaking, with diabetic education. Following that, we're very treatment heavy. They have the injectable or oral medicine lectures, the injectable lectures, and then cardiovascular issues and focusing on the treatments of those. This lecture falls kind of in between. It takes off where we left with Dr. Dow, focusing on how to diagnose the different forms, but more importantly, we're going to put an emphasis on the prevention model. Okay, so this focuses on pre-diabetes and metabolic syndrome and sort of these precursors to disease states that are highly detectable and preventable if you know what you're looking for. So again, just to recap the things that we left off with Dr. Dow, the diagnostic criteria, the A1C over 6.5, the fasting plasma glucose of 126 or more, the 2-hour glucose or a random glucose of greater than 200. A lot of people are not cognitively aware of how diabetes really evolves, especially patients. You talk to patients, at least in Oklahoma in the South, and they tell you what the diseases they have, and then they say, I have sugar diabetes. Well, what other kind is that really? But a little bit redundant there, but they always focus on the sugars, and there's never an emphasis on the insulin and the pathogenesis of how this comes around. So you first start with insulin resistance, okay? And you can test for this. You can test for insulin levels. I do not recommend that. Very expensive and not worth your time. But the point is, the very first thing you would detect in a patient who ultimately becomes diabetic is high insulin levels. The body has a large physiologic reserve. It can compensate for a lot. So as your sugar levels try to go up, it can compensate through your pancreas and those beta cells by cranking out a bunch more insulin, and your sugars stay in range. But it's taking more and more insulin to accomplish that in the early stages of diabetes. So you don't get that hyperglycemia at the beginning. The postprandial glucose is the next thing to climb. That's why I am a strong advocate of testing postprandial sugars or those 2-hour glucose tolerance tests. Yeah, they're a pain, but on the other hand, that's the next thing that you can see, because as that insulin level goes up, eventually you reach a maximum point of how much the pancreas can make. So then if you overload it by eating at Golden Corral or some other buffet, then it can't go anymore, and you get a brief blip where your sugars do in fact go up about an hour after you eat, and then they come right back down again because you still have enough circulating insulin. So your overall A1Cs are still normal again, because the vast majority of the time your sugars are in range. It's only that brief period after you eat a large carbohydrate meal that you can overload the system. So then fasting glucose levels start to go up. That's when you actually start detecting it by conventional means with the A1Cs or your fasting plasma glucoses in the mornings. So that's the next way that we detect it. So that sequence is a very important slide to me, because even though within the last 3 years we've said that, okay, A1Cs are now a means that you can actually use to detect and screen for diabetes, it's really one of the last screening tools to come back positive. Meaning it's a very specific test that if it's high and your A1C is 6.7, you're definitely diabetic. The problem is, if it's 5.8, what are you? Or even if it's 5.5, which is technically normal, sometimes some of those people can have an abnormal 2-hour glucose tolerance test. So if they're very early in the disease state, you are not going to catch it with an A1C, or even a fasting plasma glucose for that matter. So then you talk about this thing called metabolic syndrome. Used to have a lot of other names, Syndrome X and these crazy other names in the 80s and 90s, but the core part of it is insulin resistance. Has genetic and lifestyle factors, mostly due to obesity and body habitus, and basically the insulin receptors are just not functioning as well as they should to recognize the circulating insulin, so the body cranks out more and more in circulation. It leads to high sugars, obviously, and high insulin levels. The part that, if you take home one point out of everything that I say in this lecture, is that insulin is a prothrombotic and a pro-inflammatory state. It leads to cardiovascular disease. diabetes by itself is not something you have to focus just on the sugars. These people die of heart attacks, strokes, and limb amputations. They don't die because their sugar was 400, okay? They very rarely die of DKA or other complications like that. They die of cardiovascular events, and it's because high sugar levels are prothrombotic, pro-inflammatory. Leads to higher levels of tissue factor, higher levels of PIA1, lower levels of nitric oxide synthetase, that basically everything that's in the counter-regulatory system to calm your blood vessels down is shot when you have high blood sugars. So that leads to cardiovascular disease. Furthermore, whenever you're insulin resistant, or kind of a chicken and egg issue, whenever you're obese and you get insulin resistant, you have increased fat storage in the abdomen. May stimulate cancer cell growth. That one's also a little bit counterintuitive. Some studies, they've speculated that the higher sugar levels as well as the high triglycerides that come with it are actually kind of like food for cancer cells, if you will. The other part of that equation is, especially in things like breast cancer that are hormonally driven, they can be very responsive to higher levels of sugar also. Vascular changes in the endothelial lining lead to vasoconstriction. That ties into the very last thing on this slide about, again, the reduction in nitric oxide. So a little bit redundant in that point that when you reduce that, you get an overall vasoconstriction plus an increase in fluid volume within the blood vessels. Plus you have all these associated lab abnormalities, which makes sense. Basically your cholesterol gets all jacked up. Your increased platelet adhesion, everything gets stickier, hence the recommendations for the aspirin protocols, and then the increased response to angiotensin II, partly why most of us recommend ACE inhibitors and similar for initial management of hypertension, but we'll get to that at the very end of the day when we talk about some of those cardiovascular issues.